morning, sir. You've taken time to be with us. Saturdays is the day the minister goes to his constituency. He's taken some time off to be with us this afternoon, and he's heading straight to Segamat after this. Am I correct? Okay. I'm going to start immediately because I couldn't help notice in the front page of the Star newspaper today. We are the fattest nation in Southeast Asia. We all know that. We lead in terms of diabetics in Southeast Asia. But in today's front page of the Star newspaper, Putrajaya is the fattest city in Southeast Asia. How did that happen? What it's saying is our civil servants are not in the best shape, Dantastri. As a nation, as civil servants, where have we gone wrong?
Thank you, Mira. First, I think Jason, while introducing you, saying that listening to your voice can be diabetogenic. So I have to be exceedingly careful in a close relationship which we have here. Thank God diabetic is not an infectious disease.
Not in the ear. It doesn't affect your ears.
Right. Now, coming back to your question, but I don't think you can look at Putrajaya in isolation. But Putrajaya is, of course, is a unique community because it sees a collection of certain group of people, of civil servants, the middle class civil servants who lead a sedentary life. And so unless you compare similar groups in other places, you might not be able to get a fair comparison between whether similar segments of society in other areas also have got the same demographic. But having said that, I think I was the one who gave the statement of the Star yesterday that we are the fattest. Most of these, not knowing that I'm going to come here today and you're going to ask me this question. You had known this, probably have delayed that answer 2 days. So having said that, that is the figure. I mean, this is worrying. I mean, beyond Putrajaya to Malaysians, I think the fact that obesity, we are, figures show, I think 47% of Malaysians are overweight and 34% are obese, and that is not something which we can be proud of. And you can see this trend coming post-independence. It's slowly creeping up as our lifestyle changes from a sedentary, from a very active agriculture-based population to a more urban society which is involved in non-physical activity. So that is one contributory factor. As I always say, physical activity has become a luxury, not a necessity. When physical activity was a necessity, that you have to work to your place of work, or work from one rubber tree to another rubber tree, then it becomes part and parcel of your daily life. So you need not invest in remaining fit. But now it's gone beyond that point because it's most of us drive to your office and then you get down, probably walk straight into the office, and there's hardly any need for physical activity. So you have to invest in physical activity, then once physical activity becomes a luxury, is it something which is available to everybody or is it only available to certain segments of society? And whether the overall environment is enabling to allow for this. And I think along the process of development, I must admit we have made mistakes, that we have not developed societies or communities or townships which actually proactively allows for physical activity as such. So that is on one part. Obesity, as you'll ask any medical profession, Venu is sitting there, a leading cardiologist, they will tell you that it is a balance between intake and output. When the intake is above more than the output, then it gets stored. And the storage is what we are seeing. So it's either you reduce the intake or you increase the output. That is the simple mechanism to it. So we are at fault at both sides. Our intake is excess, the output is less. So that is a contributing factor. Intake is excess because the Malaysian culture is very food-centered. It's very food-centered. Meetings are food-centered. Socialization is food-centered. We can't do anything without food. In my ministry, we got 5 meetings. We got a caterer which will change the plate of food for every meeting.
See, now you know why Putrajaya is the fattest nation, fattest city.
So
Cut down on your coffee.
these are the cultural things which we need to change. Cultural things which will change how we look at things. So can we socialize without food?
We can.
Can we have meetings without food? And can that transition be done? So this is the mindset change which Malaysians have done. 1. And can we choose the correct kind of food? I mean, knowledge is good, but behavior, transition of knowledge into behavioral change, that's a difficult thing. So if that is done on one part, on the intake part, then you go into the output part, is to invest time, effort in physical activity. So we are pushing this agenda. Unfortunately, we are not seeing the results. So government can give the correct messages, and I probably have to disagree with the original statement that government tells us what to do and we have not much say. But you have every say in deciding what food you want to eat. The government doesn't dictate to you what you want to eat. And you have every say in having a right to exercise, to move, to run, whatever you do. The government tells you not. Government has not reached the level of telling you not to run or not to walk. So you still have a choice. So Malaysians should make the correct choice. And that transformation is absolutely important in this war against obesity.
But so that's not happening.
It's not.
So what do we do?
Tell them, come, let's change. Maybe when you tell them, I listen, maybe when I tell them, I'd say it's got political incentives inside it. So you have to tell, so strongly tell that, look here, you have to change.
I believe in drastic measures sometimes. What about pulling off subsidies for sugar, imposing a sugar tax like some countries?
Okay. For years, we were very generous. We were subsidizing sugar. I don't know how many of you know, we were subsidizing sugar. I think for every kilo of sugar you bought, government was paying 30 to 40 cents. Last year, I managed to convince the cabinet to remove that subsidy. Cabinet being a politically driven engine, it was very worried whether people will not support the Bangsar National if we remove the sugar subsidy. And I had to reassure the cabinet, don't worry, nothing of that sort will happen. And thank God nothing of that sort happened when the subsidy was removed. And Malaysians actually received the removal of subsidy quite well, and it didn't cause any turbulence. So that is one sign Malaysians are able to actually receive things like this. Now your second point, we're going beyond that, whether taxation of sugar will be a useful thing. It has to be evidence-based. We must have the evidence to say that increasing taxes on sugar will reduce its consumption. And a few weeks ago, the British government has actually imposed tax on sugar. So we are not against the idea, we're quite open to it. But it must be, for the first phase, is I think more educational. And it can start in very small ways. For example, when I first used to go to the kampongs in my constituency for Hari Raya or for marriages, the teh they used to give you will taste very close to honey, and that is very common. You know, it's that sweet. And it is the insistence on my part that you have to please, I don't want to add sugar, and you separate the sugar from the tea as a regular practice. And now I see most of the villages in my constituency actually now separate the sugar from the tea, and that I consider as a major evolution from a practice which has been customary for a very, very long time. So we need small things like this. We need small things like this to move forward, so that the behavior of people, in as much as using this, actually changes. So, and while the government sends a message, everybody has to sort of re-emphasize on this message so that it becomes part and parcel of a total lifestyle transformation.
It needs to start at schools as well.
Right.
The food they serve in canteens is frightening, Dr. Sri.
Right. True. But as far as the food canteens, hostels, caterers who are employed by the Ministry of Education to to supply food for special programs, receive a lot of guidance from the Ministry of Health to the Ministry of Education as to what should be supplied. So there is a lot of nutritional input from that. And but like what you say, in the implementation and the enforcement of this, I will agree with you that it's actually weakness. I mean, I visited school canteens on ad hoc basis, and I've seen caterers who are taking the shortcut route of buying nuggets which can be fried, because probably that's a cheaper route rather than actually producing wholesome food. And this is something which is not the policy, neither of the Ministry of Education nor the Ministry of Health. It is the enforcement of the policies which are already there to make sure that whatever has been laid down is being practiced. So I totally agree with you. Not only the food which is given in the school, but the educational process within the curriculum itself, so the children are educated from the very start in the correct choice of food. And we have now started a program where I've instructed the nutritional division of the Ministry of Health to target 3,000 parent-teachers associations, because the message should go to parents. So the mothers will be the best influences of the children on the dietary intake, either at home or in the school environment itself. So through their interaction, so through the programs and educating the mothers as the agents of change, we hope that this idea, because along the obesity, the other worrying thing which we have is an increase in what we call childhood obesity, that means obesity within school children itself. And this is something which is worrying, because that it gets translated into adulthood obesity and the consequent risk of all the other things. So we have to start. I mean, I cannot agree with you more that we have to start from the schools, in the curriculum, influencing the parents, the mothers, and the entire environment, the ecosystem within the educational system, so that it can be proactive as far as this goes.
So we have a dual healthcare system. We have the public sector, we have the private sector. Do you think that's working well for Malaysians at the moment?
Well, the existence of the public sector healthcare system, which I think all Malaysians should be proud of, because you see, in dealing with health system, there are a few things which we look at. One is access of the health system. Number two is the equity of the health system. Number three is, of course, the quality of the health system. Number four is the affordability of the health system. If you take these four parameters as such, the public health system has provided access. You see, I was in Sarawak 2 days ago, and it's remarkable how in the most remotest of villages, we've got health clinics, which have the X-ray departments, which got machines to do full blood examinations, biochemical examinations, urine examinations, labor rooms with ultrasound, where mothers, pregnant mothers in the remotest of clinic can have ultrasound facilities. These are facilities you don't find in many, many parts of the world. So that access is provided by the public health system. So the public health system is providing access to the most remotest villages in the country. We are having health systems where people, immaterial of whether you can afford or not, have got access. And then whether there is equity. Equity means that the government by policy says everybody has a right to come to our system. You don't have money, we'll take care of you. For 1 ringgit, we'll give you 300 ringgit worth of medication, send you back home. And so that provides equity. Third thing is where the challenge comes, is quality. So when you have a system which is so widespread, the challenges of quality, of course, comes in. And this is that we are trying to deal with now. Because quality involves many factors. It's human resource, infrastructure, being able to keep up with the latest of technology, and these things. That is a challenge, because that is a cost element to it. And any system in any part of the world cannot boast that they can pump in money in an indefinite basis into a bottomless pit in the hope that you can maintain quality. So that is a challenge. The fourth one is affordability. This is the thing why when the private sector and public sector is the private sector is a good complementing service, because at least those who can afford, they're going to the private sector, they're not burdening us, and that much there is a supplementary health service. So in a way, both the systems have complemented each other, but there are challenges to it. The long-term sustainability, but I won't go into that answer. Probably you got a question on that, so I'll reserve it for that.
Yeah, we are the private sector. It is expensive, and I think most of us would love to go and get private sector sort of treatment and service, but we can't afford it. On the other side, you have government, you have long waiting periods. We're worried about quality, Dr. Sri. We have too many doctors now. We have no idea where they're coming from. We don't know how qualified they are. I am afraid to go to government unless I know somebody in there.
No. I think all these questions are based on wrong premises. Let me take one by one. First premise is quality of doctors. Immaterial, wherever they come from, there are a lot of very leading doctors sitting in front here. They will all testify to this, whatever I'm saying, because they all are products of that system.
And many in the private sector now.
Yeah, but they went to private sector after being trained in the public sector. We trained them well. We trained them well and they became the beneficiary. Isn't it, Venu? True. He's a product of IJN, well trained, now he's in private sector. Ashok is a product of Malacca General Hospital, reasonably well trained, and now he's in the private sector.
Reasonably well trained.
And so they all are products of the public sector. They were trained in the public sector, and of course they went to the private sector. And so the public sector, one of the best things in our public sector is our capacity from wherever you come, we will mold you, train you, prepare you, give you adequate amount of skills. That is within our public system. So I can reassure you, please go to the public sector, don't worry about quality, be rest assured, you need not know anybody. There's no need for any kind of recommendation, you'll be getting good care. But you must be able to wait in your queue to take the turn. So as quality is concerned, when I mean quality just now, not in the quality of treatment, quality of doctors, they can come from any part of the world, but we got reasonable legislative, regulatory processes to ensure that we monitor them, their quality is okay before they actually touch you. So that's fine. The next point is, of course, when I meant quality is, I was talking about this waiting. Sometimes you wait for 3 hours. Can we cut down the 3 hours to 1 hour? That of course relates to the quality of time. So that is what we are working on, and we hope that with the changes which we are trying to make, we can reach that level. And in the long term is how this cooperation between the private and public can be further enhanced so we can actually benefit from both systems.
We know that the current health system, in terms of refinancing the cost of healthcare in the country, it is not sustainable going forward. What do we have planned? We spoke about the one care policy a few years ago. It was politicized, it was shelved. So where are we going with this? We cannot go on the way we are.
Right. Yes. If you look broadly, globally, their health systems can be based on two methods of financing. One is method of financing of general taxation, like what we're doing, which is done in the Scandinavian countries, Sweden, Norway, Denmark. They all follow this pattern of financing based on general taxation. Or it's on a people's insurance contribution policy, like what happens to the United States and other parts of the world. But the only difference between the general taxation, which is done in Malaysia, and the general taxation done in the Scandinavian countries, is in Malaysia, a lot of Malaysians don't pay tax. So the number who pay tax is very small. And even those who pay tax, you pay a minuscule amount of tax. Whereas in the Scandinavian country, an average person pays 35 to 50% tax. And on top of this, they pay another 20 to 30% on social security tax. So about 60% of the income
actually goes back into the government in some way or other. So with that amount of money, of course, the state can give you a lot of things in return. But if our general taxation remains the way which we have now, then you expect the government to give you that service. Economically, I'm not an economist, but I think even in the common sense economy, that is not going to work, because the amount you're receiving is very little and the amount you're expecting is too far. That's why the taxation is concerned. The insurance, of course, is asking people to contribute. I mean, that has been the one which has been raised again and again, but it becomes a political issue. It depends on when we start. I mean, if we start it just after an election and finish it within 2 years of post-election, maybe you can push it through. When it comes too near election, it becomes over-politicized, and you cannot sell the cause, because even when we wanted to increase the 1 ringgit in the outpatient department to 2 ringgit, people didn't say it's 2 ringgit, it says 100% hike. So you see, so that is the Malaysian perception. In Malaysia, you give anything, you want to take it back, it's very, 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 very difficult. So with that, I think it's an educational process, trying to tell the public that you will be, there's nothing comes free. What we have done now is now to create the awareness. Now we are trying to give an itemized bill. You go to hospital, they are supposed to give you a bill saying that, hey, look here, your stay here is 12,000 ringgit, but the government has given you 99% discount, this is the bill. So at least they are aware that there's a value to what was done for you. Otherwise, we have this perception problem. Anything which you pay money has got value, anything which has got free has got no value. So we have to break this perception problem.
Is it also got to do with priorities? How much of funding is actually coming towards health? The WHO says countries should spend at least 5% of GDP on health.
Okay,
we're spending less than 5%?
See, our total expenditure on healthcare is 4.4% of GDP, half coming from private, half coming from public. And of course, different countries spend different. America spends about 17 to 80% of GDP on healthcare. And but despite that, President Obama has not managed to solve Obamacare. You know, he still have not been able to solve Obamacare. It's still a major issue, 17% of GDP. So if you look at dollar to dollar, for our 4.4% of GDP, we have actually achieved much more than most of the countries who are spending 8 to 9% of GDP. So in that sense, we have got an efficient system, which is given us value for money. Whether increasing this is the only answer, yes. But if you look at the overall budgetary thing, Ministry of Health gets the highest amount of budget next to the Ministry of Education. So that 2 ministries will get the highest amount of your budget is the Ministry of Education. Next is the Ministry of Health. So in that sense, our budget is about 10% of the overall country's budget. Ministry of Education gets about nearly 20%. So we can push it a bit further, but you need other things. You also need roads, you need bridges, you need... so we have to work out a good deal.
Priorities. Right. We also have a lot of leakages in the system.
Right, that's not part of health.
A lot of that can come towards healthcare. When you talk about the Trans-Pacific Partnership, and I think cancer is a big problem in the country, I think cost of cancer is a huge issue. I think the George Institute study just showed that half of our cancer patients are economically challenged after 1 year of treatment. What do we have planned for cancer treatment? And the TPP is affecting biologics, which is immunotherapy, which is already very expensive. How will the TPP impact all of us in this room?
Okay, I think we shouldn't couple cancer with TPP, just a little TPP alone. There was a lot of wrong perception that TPP is going to push up healthcare costs. Basically in the area of pharmaceuticals, because there were some provisos in the TPP on intellectual property protection. But we had a long negotiation. I mean, 2 years, and I myself directly met with the lead negotiator from America many times, in which we did not give in to many of the things. For example, the initial requirement. Now all drugs which are patented in Malaysia through my IPO is given a 20-year patency. And the initial request in the TPP was to increase it from 20 to 25 years, which we did not agree, and they also eventually agreed. So in the final agreement, there is no increase in the patent period for drugs is concerned. So the patent period is the same. The only compromise which we did there was, if there is any delay in registering a patent product because of bureaucratic delay on our part, then we will compensate for that delay, which we bravely agreed, because we were very confident that our system will be able to register any product within the period of time which is stipulated, or much earlier than that. So in theory, TPP doesn't affect patency of drugs. So it doesn't increase, it's the same. So drugs which are patented will not. So coming to the next questions on biologics which you asked, why this was overplayed by people was, biologics have been given a protection of some of the confidential drug information which we call data, exclusive protection for a period of 5 years, and like any other product. And whether this will delay the possibility of developing other drugs similar to the innovator biologics, which we call biosimilars, at a faster time. The answer is no. This also comes with inadequate understanding of this whole issue. Because we went back and studied all the biologics which have been registered in Malaysia so far. All biologics which are registered in Malaysia so far have also been patented. So once you patent a biologic, you already got a 20-year protection. So this 5 years data exclusivity doesn't in any way affect you at all, right? So this only becomes useful, only becomes the issue to consider if there is a biologic for which the company which is innovated it decided not to take a patent, which is very unlikely the company will do it, because once they find a new product, they will definitely patent it because they want the 20-year protection. And they didn't take a patent, and they're completely relying on data exclusivity as their thing. Even if they do that, we have gone back and looked at all data, which shows that for any other company to develop a biosimilar, similar to the innovator, takes much more than 5 years. So the data exclusivity of 5 years will never actually cause a real effect as far as availability of drugs is concerned. So this fear that generic availability or increase in cost of generics will become more because of TPPA is totally unfounded and based on inadequate understanding of the entire process of registration. So I can tell you that that is not true. Whatever is available now will be available, but the cost of biologics is expensive.
Very expensive.
Because there are innovators, the companies which have patented them, they made it very expensive, and how to make it less cost is something which we have to negotiate with the companies for the patients and try to bring down the cost, because once the drug is patented, we have got no way we can produce another biosimilar until 20 years time. So this is one of those things which you have to live with, because otherwise the arguments of innovators is the other way around. You see, when we argued in America, I mean, in TPPA, the countries which supported increased patency were America, Japan, to a lesser extent Australia, because these are countries that produce drugs. The rest of the 13 were consumers. Their argument was, if you don't incentivize innovation, where are you going to get new drugs?
So if you don't allow companies who invest billions into the development of new drugs, some kind of protection, how are they going to recoup the investment which they've done? So this is a difficult argument. Either you want innovation, either you want new drugs, or you want status quo to remain forevermore. This is what we have to understand.
Moving on to cancer. 1 in 4 of us is expected to be inflicted with cancer by the age of 75. That's a frightening number. National Cancer Society President, Dr. Soundri, I don't know whether she's here, she's part of the panel. She has said that there is a need for government to formulate a comprehensive national cancer plan to deal with the detection and prevention of cancer. Are we doing anything about that?
Yeah, we got a national cancer policy. But cancer is not one particular disease. It's a spectrum of many different diseases which every other part of the body organ can become cancerous, and our approach for different cancers is different. One, I have not been too happy with the National Cancer Registry. And again, our Pantai chief is here, and I can address this question. Collection of data is important for any registry. And public sector data we have. We have a very comprehensive public sector data. You ask the number of cancers in the Ministry of Health, how many breast cancers, how many ovary cancers, how many colon cancers, we got complete data. So we can review the data, but that doesn't reflect the total cancer load of the country. Because our access to private sector data is limited. You see, that we only get private sector data is when the patient dies, because they have to inform mortality. So we get the data from Department of Statistics when they sign cause of death is due to CA cervix, cancer of the cervix. We get the data and that adds. But when they're treating a patient with cancer, that data is not available to us. So because of that inability, we are trying to see how we can overcome this hurdle. Because the private hospitals, their issue is my patient's privacy. I want to protect my privacy, so I can't provide this data.
Your government, you can make them do it.
Yes, certainly, with your support. Right. So if I do it, it's not my doing, it's Mira's insinuation that I should do it. So you can hold her at a ransom for that.
We need a national cancer registry.
So we are looking at legislative possibilities of making sure we get that data. Because to start off, that information is vital. See? I don't want to be then our cancer oncologists and anybody here going on our meetings and presenting American data. I've asked many of them, what are you doing here speaking in Malaysia, giving me American data? Please give me my Malaysian data, that's what I want. So, but this is very, very important to start off. So we are pushing the National Cancer Registry so that we will get the latest data, the correct data, which is representative of the national. Having said that, for every particular cancer, because we have got different interventions, I'll just give you one very good intervention which we've done is for cancer of the cervix. One of the causes of cancer of the cervix, which is considered to be an infective thing, human papillomavirus. And we have started vaccinating young girls at the age of 12 in secondary schools against human papillomavirus, and we are one of the few countries in the world who have actually reached a level of 98% coverage of our young girls vaccinated against HPV. I didn't know that. When I presented this data 2 years ago in the APAC meeting, and Americans were shocked that you actually could achieve such a degree of outreach. They couldn't reach outreach. They say even 60% outreach in America is a big thing, and we have reached 98% outreach of all young girls in our secondary school, I think Form 2 or Form 3 are vaccinated HPV. The benefit of that program will only be seen in 15 to 20 years' time, when you'll see a reduction in the number of cases of CA cervix. So I'm just giving you one example. So likewise, for CA breast, for example, our mammograms and screening and mobile clinics are going all over the country trying to detect early. But people must come for it.
See, when our health screening programs go on the ground, asking middle-aged ladies to come for pap smear, telling them at least once a year, you can have a pap smear free of charge at government's cost, the willingness of the people to come and get it done is important. So this is the way going forward. As far as government is concerned, for breast cancer, for CA cervix, we have got, and for lung, the anti-smoking campaigns, all these programs are going on. These are the preventive campaigns and early detection programs. So there are, but not in one thing as cancer, but it's done under different programs which can be all working towards one common target. But our initial thing is, of course, to make our register.
Sure. While we're talking about vaccinations, we seem to be hesitant to take on the dengue vaccine.
Yeah.
We have a huge problem with dengue in Malaysia. We seem to want to study a vaccine which has been studied. Why is that?
Right. Lokman, you just directly opposite me. I'll tell you why. First of all, I'll be the happiest person in this country if you give me a vaccine today which meets all the requirements of eradicating or addressing the dengue problem. Unfortunately, this vaccine doesn't. For many reasons. I mean, I won't go into all the details. The viruses which cause dengue, there are 4 serotypes, we call them. 1, 2, 3 to 4. The one which has been our biggest problem is the second, DEN2, we call it. And if you look at the protection of this vaccine against these 4 viruses, Lakman, you can correct me if my figures are wrong. Its protection is higher against the DEN3 and DEN4 compared to DEN2. DEN2, I think, is 47%. Its protection is the lowest. So it provides the lowest protection against our biggest problem. So that's one weakness of this vaccine. Second weakness is the prototype of our dengue patient is a middle-aged person. Our dengue patient prototype is somebody between 20 to 30 years old. This particular study showed that its efficacy is from the age of 9 until the age of 18. That is the period it is effective. It says it could be dangerous for those who are less than 9. It could be dangerous, that there is a risk they can get more illness. And we don't know how good it is for those who are in their adulthood. So that is so within that spectrum, there is this vaccine. It doesn't protect against the virus, which is my biggest problem. And I don't have the data to know whether it protects that population in my country which is at highest risk. And on what basis am I going to approve this vaccine?
Just want you hold that thought. We spoke to Professor Emeritus Dr. Lam Saikit, Asia Pacific Steering Committee for Dengue Vaccination Program. 30 years, he's worked 30 years on the dengue vaccine, and this is what he had to say.
The vaccine has been tested in over 40,000 people in 10 countries and has been thoroughly evaluated under international guidelines. I really do not see what else Malaysia can do to try to study this further. All the evidence are there. The details of the study have been published in top journals and it has been accepted. The vaccine, as recommended by the manufacturer, is for use of children from 9 to adults of 45. So there is already evidence that it is effective. This is a tetravalent vaccine, that is a live vaccine that's protecting against all 4 serotypes. An overall vaccine of this is 65% actually, not fit for in Malaysia. It is in the 50s, but if you combine the result from Malaysia and the Latin American countries, it is above 60%. And to me, after 30 years of seeing this vaccine being developed and coming to this stage, I believe that it is good enough for use.
Right.
Your views.
I am not a virologist, but I can get a few other virologists to put similar videotapes with the different views. That is how that speciality is divided on this issue. the speciality is divided in this issue. So there is no uniform view as far as this is concerned. He belongs to the other team, not only he, there are 2 other 3 virologists who worked on the project who have got a different view. The others who have objectively analyzed this, who have got a different view. But we are not, but I'm telling you, I'm not totally against it, as I told you just now. It is, there's evidence shows it does protect from 9 to middle age. He said 45. That is by collating certain evidence, but not correct data-based evidence. So that is one. Number 2 is, it did show 2 other advantages, which fairly one, which is it can reduce the amount of serious disease, which we positively accept. And it also reduces the risk of hospitalization. So for these 3 reasons, we are still not closed the doors against the vaccine. We have not closed the doors. We have asked the pharmaceutical division to study its registration process, because they have got a process of validation before they register it. But our concern is whether it's going to become part of a national immunization program, or is it going to be available to small sectors of people, or whether it will be registered and if you want, you can vaccinate. These decisions are difficult decisions for the government to take, so this is what we're studying.
Okay. Do we have a time frame as to when we'll know whether or not?
Well, I think we said by June we will make some decision.
2016.
Yes.
Fantastic. I'm going to open up the floor for questions. Anybody got a question for the good minister? This is your chance.
For the good minister.
Good morning.
Good morning.
I'm Mahadevan here. Now, I think we had very good explanation from the minister. I think you have been also asking him a lot of questions. But I noticed that we have not touched the subject on preventive medicine. Now, I'm now 69, and I do a lot of reading on preventive medicine, and I practice preventive medicine. And I'm glad to say my diabetes is now under control. The reading is between 4 to 5. Now, I've spoken to many people of my age. They don't know anything about preventive medicine. What they do is, I believe in my doctor, and my doctor prescribes medicine, and now it's not working anymore. So, I don't know. I have been practicing wellness, and I see very good results, and I hope to live beyond 100. There must be a definite program to teach our people, all of us, on practicing wellness. Maybe the minister would like to say, comment on this.
First, can I know what is your understanding of what is meant by preventive methods of wellness? I mean, because your concept of prevention and another person's idea of preventive medicine might be different.
My understanding is our human body can look after itself.
Good.
Provided we do the right thing, lifestyle has to change, and we must reduce the amount of drugs.
You said 3 things. Do the right thing. What are the right things?
Well, practice lifestyle. 2, take supplements which are natural.
So basically you are saying prevention involves taking of supplements.
Well, I have done that, and I think I have managed to control most of the degenerative diseases.
Okay.
Thank you, sir.
Right, thank you. So, and this is a debatable issue. Well, I mean, of course, the world of supplements is an entire industry by itself. Some driven by advertisements, some driven by studies which are focused on one line, on the other line. And of course, different thing works for different people. Different people will swear by different brands. So for us to make conclusive evidence, I can only give a very general scientific statement on this, is there are certain things which are proven. And from the mainstream medicine, and that is the things which we should accept. Right? So what is accepted by mainstream medicine, and that is what we should accept.
the world of supplement medicine, world of complementary medicine, there's a huge one. So people who are following it go by their choices. It works for them, fine. But what one person will swear on is not what another person will swear on.
It's very anecdotal.
Right.
Yeah. Another question then.
Good morning, Dr. Sri.
Morning.
Good morning. I'd like to ask, since our Malaysia, we have a lot of natural plants, and if I'm not wrong, even the Western researcher came to Sarawak to collect some of our herbs and for the AIDS treatment. And even the reason why the pharmaceutical, the international, multinational corporation, they are not interested in this our natural herbs because they cannot patent it. Okay, and also they know that they can, what the use of doing these clinical trials when our population can plant it at their own backyards. Okay, and what can we do in our Malaysian pharmaceutical local one? With the traditional and herbs, for example, like the misai kucing, it seems that they have a very good effect on cancer treatment and also prevention for diabetic and hypertension.
Okay, let me. Your question is, if a Western company identifies the use of a local herb, can they patent the herb so that we can lose claim over it? The answer is, of course, there are many processes to it. You cannot patent the herb, of course. But if your process has identified a very active ingredient within the herb, which has shown definite positive benefits for whatever it is, and is undergone the normal scientific process of validation, and through that you have come out with something, then you can patent that particular chemical compound, and you only own that. If you want to say that I want to patent the herb, I mean then half the herbs in this country will be patented by countries which otherwise. So that is something of concern. But active ingredients coming from natural herbs is something historical. Like you ask a cardiologist, there's a drug called digoxin which is still using. It came from a herb, how many years? 100 years? Maybe 100 years ago, foxglove. It's a herb called foxglove about 100, 120, 150 years ago, and it is patented because the active ingredient was identified and patented. Likewise, for many products, which the active ingredient identified, the chemical has been patented, so it can be used. But so that is the process. So whether our biodiversity can contribute to active pharmacological ingredients, answer is yes. Is there any work being done? Yes. The Sarawak biodiversity. Most of our universities in Malaysia, their pharmacological departments are working on local herbs. They are all trying, even for dengue, they are trying to find out what's the active ingredient. Papaya juice was tested.
Yes, tell us about papaya leaf.
Papaya leaf.
There's a lot of talk about papaya leaf.
Well, papaya leaf, the juice has been, papaya leaf for dengue has been studied by IMAR, and it shows that it makes you feel better. The febrile phase comes down. The inflammatory process of the infection comes down, but the viral count doesn't come down. So the virus is still alive. It doesn't kill the virus, but you feel better. But the inflammation associated with the disease does come down. So for that purpose, it's good. But there are works to find out more about what is the ingredient, what is the active ingredient in that papaya juice, which actually provides these particular benefits. So all these works are going on. We have to come out. It has to go through the scientific process.
There's a Twitter question. What does the good minister do to maintain good fitness and health?
It's going to privacy. Right. I'm a vegetarian.
Okay.
For a start. And then I think all this stress keeps you healthy.
You're not answering my question.
In
in politics, we learn the art of answering some and not answering some.
I'll let you go on this one.
All right, anyway. So that is it, and I do exercise whenever I can. I don't smoke, don't drink. These are the things.
Okay.
Right?
Good
Okay.
enough. Good
Malaysians can follow that if they want.
Just to conclude, we will be an aging nation in the year 2030.
True.
Which means 15% of our population will be 60 years and above. Are we ready for that?
Well, that's a challenge, and many countries already reached the stage. Japan, very obese. For us, how are we going to be ready for that? That's a very complex issue. It's got economic connotation, the social connotation, has got health connotation. So we have to be ready in all perspectives. Economic connotation, if you live longer, will you have enough wealth to sustain you for that period of time you're going to live? Very big issue. How are you going to answer this? If your EPF, which you're contributing till the age of 60, now, how long will it sustain you? Maybe until the age of 75? What do you believe until? Somebody says no. So she doesn't even agree to that. So maybe lesser than that. If you live like 100, like uncle is going to live for 100 years of age, where is this money going to come from? So there are only two ways you can address this issue. One is to increase the productive years of Malaysians for a longer period of time, which means, are you going to allow people to retire later? That means 65. Can people work until 70? Or people will be allowed to work as long as you want? That's one issue. Number two is here's the social issue. We had extended families, parents lived with children, which is breaking up. You can go to remotest kampongs, you find old people suffering by themselves, and they are the most impoverished, because growing old is not a problem, but you must grow old healthy. You have to grow old with money. See, when you grow old without money, then the poverty in the elderly is a very painful process. So that is another thing which has got to be addressed. It's an economic consideration, a social consideration. The third, of course, is the health consideration. As you grow older, you become, of course, you will have illness. You will accumulate the number of drugs you're taking. So that goes on, so all these things have to take care. So as it is, I don't think we are yet ready. So there has got to be a major transformation into the socio-economic environment to actually face these challenges and identify some of these as to be very drastic challenges, because we are growing old is a reflection of the success of our growth so far, right? The fact that our lifespan, which used to be 57 at the age of independence, in 1957, the average Malaysian lifespan was about 55 to 56. So retirement age then was 55. That means retirement age was fixed at your lifespan. Now, the lifespan is 72, 73 for males, and I think 76, 77 for females. So are we going to increase retirement age until 70? Challenge. So it's not an easy answer. That is something which we need to think of. If we allow old people to work until 70, where are the jobs for the young guys who are coming out of colleges? So these are the challenges. But it's not an easy answer. It's a very complex issue. Needs multi-sectoral involvement and the whole of government policy.
Your message to all of us here.
Right. I go back to what Mira's original statement was. Health is your concern, individual, you take care of your life. So it's personal choices. So make the right choices. You've got in this democratic country, you've got right to choose what food you eat. You've got right to exercise. You're right not to eat what you don't want to eat. Make the right choices. I think Malaysians' knowledge is good. Transformation of knowledge and behavior is poor in every aspect. Everybody knows Aedes aegypti causes dengue, but attempts to eradicate Aedes aegypti is very poor. So these are the things. Let us
translate knowledge into behavior. The day we translate knowledge into behavior, then many of these issues which we face will be resolved and this country will become a better place for us to live in. Thank you
I
very
just
much.
have one more question. I have. Are we ready for an epidemic like Ebola?
Right, we are. As far as health system is concerned, we are. In fact, during the Ebola crisis, we had all the infrastructure ready in case any case comes, how to manage it. And I'm fairly confident we would have managed it fairly well. We would have managed it fairly well. Even when nurses were trained how to gown and how to take out their gowns. In Ebola, even that was important. Because in Texas or in one of the American cases, it was transmitted by the nurse in the process of removing a gown. That's how she contacted it. After dealing with the patient with Ebola. So we actually trained them through the entire process, through videos. They were shown, this step. So we had actually created the infrastructure. If we had a case that come, rest assured we would have controlled it. So I think we are fairly good in the infra. In fact, we worked with them. We were helping management of Ebola from here in analyzing data and giving feedback to them and certain issues. So through our crisis response center. So we have got a crisis response center in the Ministry of Health, which is on a standby at all times and can trigger off into crisis mode anytime which we want.
Fantastic, that's very good to know. We wish you a very happy birthday and many happy returns
This has
of
become
the day.
national news now. Thank you very much.
Thank you for joining us today.
Yes, and right now, Amira will give a very small token of appreciation to our minister. Thank you so much for making a time.